Of course. Welcome to our monthly, sometimes bi-monthly reimbursement and denials work group meeting. Lydia of CTEL put together this wonderful presentation on the Medicare Physician Fee Schedule proposal that came out a couple of weeks ago. And there are some interesting things that'll affect non-facilities and facilities. So I think everyone will enjoy this. And Lydia, on over to you. Thank you.
Great, thank you so much. I'm just now putting in some documents into the chat to help you follow along. Included is both a copy of the presentation for today, as well as the more complete summary of the fee schedule that CTEL completed a few weeks ago. I'm also going to put in the chat links to both the fee schedule proposed rule, as well as the OPPS proposed rule as well, just so you have everything for reference. And if you want to go back either during the presentation or afterwards. So just to start out with a little bit of background on the physician fee schedule, this is a major rule that comes out of CMS every year, setting annual payment policies for Medicare. And the focus on payment is really important because that's what all of these policies are centered around. What is Medicare paying for? What is Medicare not paying for? And how much is Medicare going to pay for all of these services? And so these proposed changes were released July 9th and 10th. And so the comment period thus will be a 2-month period that closes on September 9th. And so it's important to note that these are proposed rules and proposed policies. And so between now and when CMS releases the final rule, usually early to mid-November, CMS will receive all the comments from organizations like CTEL and review them and then issue a final rule. And oftentimes the agency does make changes in between the proposed rule stage and the final rule stage. And so to help CMS in its policymaking, CTEL is preparing a comment letter to the agency, providing feedback on the proposed policies, sharing some of our research, as well as the expertise from members like you. And so to begin, we're going to go through some of the major telehealth and digital health policy proposals in the proposed rule. And most importantly, we have prepared a few discussion questions as well to help guide our interpretation of this, as well as help CTEL staff in preparing our letter on the rule. And so one of the biggest policy provisions that came out of the proposed rule is a revised definition to interactive telecommunication system, which includes two-way real-time audio-only communication technology if the patient is not capable or consenting to two-way audio-video communication. And so this has been a really welcome change to see that CMS is going to allow more flexibility for patients and providers in being able to access telehealth through audio only if, for whatever reason, audio-video communication is not available. And so the first piece that we wanted to discuss is the updates to direct supervision. And so direct supervision, the flexibilities around allowing audio-visual communication technology to be satisfactory for this have been extended through the end of 2025. And so I'm curious to hear from you all what your experience with audio-video communication for direct supervision has been, and whether or not you think that CMS is ready for a permanent extension, or if more data is needed before that decision can be made. And likewise, if any of you have experience with teaching physician or resident fellow supervision, if services are no longer payable in most instances, do you think there's a point in continuing this expansion?
I just want to interject really quick about the teaching physician rule.
Recording in progress.
It does say that I think it has to be three-way, like the attending and the resident all need to be remote away from the patient. And we often have residents with patients where the attending zooms in. And so it's not really the way we've been doing telehealth. And another thing is if, you know, if Congress doesn't act and geographic limitations go back into play, then it's a moot point anyway. So, fingers crossed on things being passed, but I'm not going to hold my breath. See Jessica unmuted as well.
Yeah, I did. Yeah, Carol, I think we're doing a very similar process with supervision of our residents and fellows. Is um, the resident or fellow is with the patient, and then the supervising physician is added as a participant on the call in some, or on the video call in some way. So I think we found it to be very effective to do this. I would like to see it extended, made permanent, because we do cover a large geographic area in 3 states. It's been very helpful for us. But payment is one thing too. Then if it's not paid, then we probably won't continue it. Unfortunately, because it gives residents a great tool in their tool belt to learn these skills.
And similarly, looking at providers eligible for telehealth payment, this comes out of the outpatient prospective payment system proposed rule, but it says that outpatient physical therapists, speech language pathologists, and occupational therapists will no longer be able to bill for Medicare telehealth services beginning on January 1st, 2025. And so this comes out of the many restrictions that CMS has absent congressional action to continue a lot of these PHE era policies. And so I'm wondering, for those who have experience with this, do you think that CMS or the administration should advocate for the authority to cover these services, advocate to Congress specifically? And also, what do we think that the intent is on leaving the CPT codes for their services on the Medicare telehealth list as provisional services?
I'm just full of comments today. So I was listening to a Coding Intel presentation this morning, and they had said that they left them on there because if an MD or another eligible provider did the service, then it would still be on the list. But I kind of think Betsy might have been a little bit off on that because they're not, I don't think these are sometimes therapy codes. I think they're specific to PTs, OTs, and SLPs. So hopefully they left them on there just in case Congress acts as well. That was my thought when I thought about it a little bit more. But now of course I'm going to go bug Betsy about correcting her slides.
Yeah, and definitely a big part of throughout this rule is, especially when it comes to telehealth policies, is that CMS is kind of trying to both act under the assumption that Congress will not do anything and that everything is going to expire at the end of this year, but also trying to leave some kind of room for either continuity of care in that case, or if Congress decides to make these extensions by the end of the year, what can CMS do to then react to that as quickly as possible? And on an expiring provision for this year is originating site provisions, which starting in 2025, telehealth will only be covered in rural locations and facilities as originating sites, like hospitals, doctors' offices, and skilled nursing facilities. Beneficiary's home continues to be a permissible originating site for certain types of services, including those furnished for the diagnosis, evaluation, or treatment of a mental health disorder, including a substance use disorder, and for monthly end-stage renal disease-related clinical assessments. And so again, this is another big thing that the agency is not going to have the authority to beyond 2024. And so as part of our comment letter, we want to see how this is going to change and affect your practice, and what patients and communities do you think will be most affected by this reverting back to pre-PHE policy.
Well, the vast majority of our telehealth is being done from a patient's home, from their office, from wherever they're at. So, I mean, it would crush us, to be honest. So it would, yeah, more than half of our telehealth. So.
I'm just going to interject here real quick because I don't want the proposed rule to incite panic. This is Krista with CCAL. We've been in conversations with congressionals. We anticipate that there's going to be an extension till 26, but we're not going to be able to finalize permanency if that's where Congress wants to go until the 119th Congress. So we're Jess, you're probably you're probably in a good space right now that at least for the next 2 years, we likely have an extension on the reimbursement piece. The piece that is that has nothing to do with reimbursement is the issue with DEA. And that's the real big question mark at the end of the year, because unless DEA acts, that will permanently go away. But anyway, go ahead, Lydia.
Yeah, and part of what's kind of creating a lot of confusion about this is that CMS has to act under the assumption that this is all going to expire. And it's becoming more and more unlikely that Congress will be able to act before the final rule for the fee schedule comes out in November, because both August recess and then there's a presidential election going on between now and then. And so Congress is going to have a lot on its plate already, in addition to the fact that, especially in the House, they're also starting to fall behind on the annual budget and appropriations bills. And so the likelihood of congressional action before the final rule comes out is becoming less and less likely. What we're seeing in our discussion with congressional offices and other policymakers is that the most likely case for this is going to be probably in December in an end of year health package, as with a lot of other health policies that come through in those kind of packages. But it's also going to be difficult, again, for CMS, because it's going to have to finalize a policy and then try to, as quickly as possible, adjust back to any sort of extension that Congress passes. And so there's going to be a lot of movement probably at the end of the year. And so it'll be important to be on top of all the different potential scenarios that CMS could be going through as it tries to act within its legislative and statutory authority.
Well said, Lydia. Thank you.
Lydia, can you break this down into two parts? Does the second part, beneficiary's home continues to be a permissible originating site for blah, blah, et cetera? Does that mean those participants has to be located in a rural location, or does that mean any home works?
Carol?
Jason, what was the exact first start of that? Because yeah, patient.
It seems like this has.
home.
I'm just curious. Does the second sentence provide an exception for what will continue to be covered via telehealth?
Absolutely. Yeah. Mental health, substance use disorder, and ESRD. Those are exceptions that are built into legislation, and they will be paid as place of service 10, and they will be paid at the non-facility rate, regardless of where they're provided.
Thank you for that clarification.
You're welcome.
And so continuing on through some of the proposed policy provisions, is that CMS reviewed 17 codes from the CPT editorial panel on telehealth evaluation and management service codes, and only one of those codes was accepted for payment, which is 9X091, which will replace G2012, and noted that CPT codes 99441, 99442, and 99443 will return to bundled status in 2025. And so our discussion question for this is that CMS believes that other proposed codes were too similar to existing codes, and we're wondering if there are any gaps in telehealth evaluation and management service codes that CMS should have filled, or codes that should have been affected by these updates.
I have
We
a
have a
quick
question from
question.
Lorraine. Oh, go ahead, Lorraine.
Oh, sorry. So for the CPT codes 99441 through 99443, will the modifier remain the same 93, or will that modifier change to indicate those services?
Oh, those codes are gone.
They're completely gone.
They're deleted. Yep.
Okay.
Yeah, they're deleted from the AMA CPT book, and
They're not applicable until the end of this year. I thought they were.
they are until the end of this year.
Okay.
Yep. And still require modifier 95. Yeah,
95
nothing's
or
changing.
93 for the audio.
They're on the telehealth services list.
Okay.
So you're
All
I
right.
guess 95, it's an audio only E&M code, but it is on the telehealth services list, probably a 93. You're right. But
Okay.
yeah, the only audio option will be that G2012 conversion. Don't know if it's going to remain a CTBS code, so we should probably comment on that. If they give it that 9X091 status, does that mean it's an E&M code, and then they're going to take it away from us as a communication technology based service? Don't know. UCSF only did 171 of those last year total. So we're not worried about it, but I guess if they take away audio only altogether, then we're all unhappy. And then the audio only codes on the permanent list and provisional are on the Medicare telehealth services list. So you'll know which ones to put in 93 and which ones get a 95.
Thank you.
And similarly, on the subject of expansions versus permanency, is looking at frequency limitations for subsequent inpatient nursing facility and critical care consultation visits via telehealth. CMS will continue to not subject those to frequency limitations through 2025 to allow for additional data collection. And same with other provisions, we're wondering if there's any data that CMS should seek in order to make this decision. And should this decision eventually move towards permanency, or should that be something that CMS phases out? And I guess I should also note that specifically CMS is trying to look for data on how practice patterns have changed. But in the proposed rule, they didn't really specify what practice pattern changes they're looking for. Just again, practice pattern changes.
In interest of time, Lydia, maybe we'd want to go through the summation and then save specific questions for the end.
Sure, that sounds great.
Okay.
And so again, moving through looking at opioid treatment programs, CMS is proposing to permanently allow OTPs to do audio-only periodic assessments when video is not available. And CMS is also proposing for audio video payment for methadone initiation intake, although currently this would not actually be allowed because the DEA and SAMHSA hasn't authorized it. But in the case that this is authorized, then CMS would be able to pay for that. And likewise, as part of the intake, CMS is also proposing to pay for social determinants of health risk assessments, again, as part of that intake. And for in-person visit requirements, CMS is proposing to delay enforcement of in-person visit requirements for mental health services through the end of 2025. In addition to a lot of telehealth policies, the physician fee schedule also has a handful of proposed policies on the area of remote monitoring. And so for digital mental health treatment devices, CMS is proposing 3 new HCPCS codes for these devices modeled on coding for RTM services. And CMS specifies that the proposed codes and payments would only really apply to FDA cleared devices. And there's a few RFIs within that policy proposal as well. On chronic care management and behavioral health integration for RPM and RTM services after January 1st, 2025, CMS is proposing that payment be based on the national non-facility payment rate. And interestingly, for what we think is the first time, the physician fee schedule is directly addressing artificial intelligence through the Medicare Diabetes Prevention Program. There's been some changes to the definitions of online learning sessions and a new stipulation that chatbots and AI forums do not count as live coach interaction. And finally, CMS has also had a few requests for information within the fee schedule. A big one is on the conversion factor. As with years in past, there's a conversion factor cut. However, CMS does note that in calculating the budget neutrality adjustment, it was done with, quote, the presumption that changes in telehealth utilization will not affect overall service utilization. And so CMS is seeking comment on what the impact of the expiration of current telehealth flexibilities would have on overall service utilization for calendar year 2025. CMS is also seeking information on whether oral sleep apnea devices can be provided via telehealth for the potential creation of new codes. On global package valuation, CMS is seeking comment on how remote monitoring and other types of new technologies represent new resource costs and or produce efficiencies and effectiveness of post-operative care. And what's interesting about this global package valuation piece is that while there's a more broader proposal in the rule, this is actually resulting in a positive budget neutrality adjustment for the first time, because it's believing that in adjusting the global package valuation, that CMS will ultimately save some money here. And so they're looking for even more opportunities for cost savings here. And finally, on telehealth payments for FQHCs and RHCs, CMS is seeking feedback on 2 proposals to ensure continuity of care for patients relying on telehealth services, as well as a changed definition of visit for these 2 locations to include audio-video communication. And lastly, one thing that CMS didn't really address in these rules is the acute hospital at home waivers, which is something that CTEL has been bringing a lot of attention to in recent months. And so we're also wondering if CMS and the administration should advocate for congressional action on this, or what potential suggestions we could offer to CMS to ensure continuity of care within its current jurisdiction. And so that's kind of our overview of some of the major telehealth provisions of the rule. And going back to some of the more discussion questions of this, looking at opioid treatment programs, specifically on the issue of SDOH risk assessments, we're wondering if this is something that is already being done as part of these intakes, and if so, how would payment for this increase utilization and or effectiveness of this process?
Well, I think it's being done by audio only. I think some of this population is not able to. They may not have adequate internet. They may not be able to get to adequate internet because they may have transportation issues, along with the other issues that they have. So, this is a population that providing some care via audio only is better than no care. That's my feeling.
Certainly, and that's something that we've also been sharing a lot in our meetings with both administration and congressional officials as well. And likewise, for the in-person visit requirements, we're wondering about the impact of the enforcement delays have had on your practice. And again, with other kind of short-term extensions, is this something that CMS should be making permanent now? And if not, what do we think CMS, what would be the data that it would need to be able to make that decision permanent?
I think it should be permanent, that they do not need to be seen in person. We've seen that behavioral health has really exploded with the use of telehealth, and it improves our access to care and access to providers. So I think it's a win-win. It's a win for the health system. It's a win for the patients who can be seen sooner. When we contract with virtual telehealth providers, we are the patient's not going to be able to see that provider in person. So to bring them into an in-person provider for every 6 months that they don't know is not going to be of benefit to the patient.
Yeah, for sure. And I'm wondering if you have any insights or ideas on especially the cost measure of this, because a lot of this hesitancy towards permanency that we're seeing both from CMS and especially Congress is about the cost of offering these telehealth services and these flexibilities as well.
Well, I think if you have to reestablish with a provider or see a provider that you haven't seen before, you're being billed as a new patient, which would be more expensive than if you are seeing your regular provider. So there's a cost savings in continuity of care, not only better care, but it's less expensive.
Certainly. And coming back to the remote monitoring proposed policies, we're looking for more information about these DMHT devices and some of the RFIs that CMS has included. One of the more interesting one is, should payment apply for devices used for specific purposes, not cleared by the FDI when the device is FDA approved for a different specific purpose? I'm wondering if anyone here has experience with that and whether or not there have been barriers to care that have been provided by this.
I was reading about FDA approval. There's a way you can list a similar use device to get approved for a new use. So maybe that would be the way to go and quicker. That would be something to mention to them.
I think that's a good point, just from a user standpoint. How many devices can they have in their house? If they can have one that does two things, amazing. And that's a cost savings.
Yeah, and that's also something that CMS is looking for on, should payment be limited to a set number of devices per month per patient? Should payment be limited if the patient discontinues using the device? And so in addition to these new codes, CMS is looking for information on how these codes should be applied and in what cases and what flexibility should be allowed here.
I think I've read some studies on devices and the length of time that that people use them. So it probably, I think it was like in a 90-day period. It was much more, the device was used more than after that 90-day period. So, I mean, I suppose it depends on the condition that you're monitoring, but that acute phase of post hospitalization, probably 90 days, that would be my recommendation.
For sure, and that's something that, as we've been looking through some of the research on post-operative remote monitoring devices as well, that we'll talk a little bit more about later, also seeing that kind of acute, immediate post-discharge period is where a lot of the most use and benefits come from as well. And looking at the artificial intelligence piece, we're wondering in our response to CMS, does CMS strike the right balance in sort of allowing for AI chatbots and not explicitly prohibiting them to be used as part of an MDPP learning session without necessarily replacing live coaches?
Yeah, I think patients for the most part, enjoy that chatbot experience because it's available all the time. I do think that the live coach should not be removed, but yeah, I think it's good to include it.
Yeah, and that's a part of the broader conversation we're having with our AI Blue Ribbon Collaborative, as well as we're preparing for our CTEL's AI Tech Showcase in March of this year, is trying to figure out how, not only what this technology can do, but how is it being integrated within healthcare. And so trying to find balances like this is something that CTEL has been really focused on in our conversations with Congress and the administration. And so looking at the conversion factor, I'm curious what your all perspectives are on what the impact the expiration of these telehealth flexibilities would have on overall service utilization, and whether or not this would result in kind of a stable, as CMS assumed. Would overall utilization decrease? Would it increase? And what perspectives you might have from your practice or from your perspective. This is something that CTEL is also kind of looking through, whether or not there'd be a decrease in utilization because access to care is being restricted. Some of the research that CTEL has piloted has shown that telehealth access reduced spending through decreased hospitalizations and other kind of downstream effects. And so this is something that we're trying to see how this should be incorporated into CMS's calculations for overall utilization and ultimately payment as well.
Well, I mean, within just my region, I'm going to have 2 counties that are metropolitan statistical areas, so there won't be any telehealth that's happening in those. Won't have any telehealth happening in the home, so that's a few thousand visits a month. Yeah. So it'll be less. They'll have to pay less. They'll have to pay something because these people will have to come in. But
I'm curious.
Their telehealth budget will go down.
Yeah, and part of looking at the cost impact study that CTEL piloted, looking at kind of how the distribution of savings in telehealth between sort of more rural areas versus urban areas. In that study, CTEL looked at the New York City, Long Island region,
Mhm.
compared to say like rural Florida, and found that the cost savings, especially in the downstream effects of like reduced hospitalization, were much more pronounced in these rural areas that will still have a lot of access to telehealth. Um, and so trying to kind of gauge that as well is part of how we're kind of evaluating what CMS is saying about this too.
It's interesting. What, where you live determines what kind of care you can get.
Yeah, and
Resource.
a big part of that from the research that CTEL did and ultimately shared with the administration was noting how in a more metropolitan urban area that access to care was a lot closer, and so telehealth played a less of a role in kind of bridging those geographical gaps. Whereas, especially in a more rural area, looking at things like specialty care access, the differences and savings were much more pronounced in that research as well.
Yeah, I can see that. I mean, we have clinics that are an hour and a half away, or patients that are traveling 3 hours to 4 hours round trip to see a provider in person. So those they would have telemedicine. But in a city, you might have somebody traveling that same amount of time. Even though they're closer, doesn't mean that the transportation is better. But
For sure.
yeah, I mean it works for us, but we're rural. We're a rural health system.
Hmm.
For Iris.
And looking at the global package valuation RFIs from CMS, CTEL has already started kind of looking through the research on post-operative remote monitoring technologies. And we're curious if any of you have experience with using those and how those has helped with whether reducing or increasing resource costs in kind of the post-operative care period. And we've been looking, some of the research we've found so far is saying that, well, it might not have too much of an effect on overall costs, but patients really like it, which, as far as like CMS is concerned from a fee schedule perspective, isn't really data or cost savings. Other research has shown that it helps with preventing complications, preventing potentially fatal complications, increasing detection of those as well, and that those might also represent potential cost savings. But again, CMS is kind of casting a net and trying to see what information can be brought kind of from a wide audience as well on this. And lastly, again, on the hospital at home waivers, this is something that CTEL has been bringing a lot of attention to, and we intend to continue kind of elevating this issue. We've been working with the AHA on this. We had a panel at this at our most recent Digital Health Summit, where we had some folks from Mayo Clinic who came in and kind of talked about the impact that this has had, especially for patients and on cost savings and everything like that. And so we were surprised to see that CMS did not address it. Again, part of this is because it does not have the congressional authority to, that there's not really much for CMS to do other than watch it expire. But we're wondering if this would be an opportunity for CMS and the administration to raise this issue before Congress as well and kind of help get this more salient to congressional policymakers as they work through this end of year health package that we're kind of all expecting right now. And with that, I think that ends our overview of the fee schedule, some of the major digital health policy provisions, and thank you so much for the discussion on this. I think this is really helpful feedback that we've gotten to help us kind of put together our comment letters. CTEL staff will continue working on this through right up to September 9th when these comment letters are due. And then as CMS continues its rulemaking progress, we will keep you all updated as well on what we're seeing from Congress as well as from the administration.
Thank you, Lydia.
Thank you, Lydia, for your hard work on this project. Thank you, Carol.
Thanks, Lydia. Thanks, Carol.
Thank you.